Hi everyone. Today let us discuss about carcinoma larynx part 4, the final part of carcinoma larynx. Today we are going to discuss about the treatment, all the various treatment modalities, the various variations of the treatment, everything. So this is a bit of a complicated chapter, but I will try to make it simple as I can. So basically there will be one first line of treatment, okay? There is going to be one first line of treatment, but there will be some cases where you can have a different modality of treatment. So you have to remember this first, and these things you try to remember after you have remembered this. Once you understand the basic principle of management, you have to elaborate on these other methods of treatment, okay? So this is the principles of management. What is the principle of management? Suppose here is a patient who has presented to you with hoarseness of voice. You suspected a carcinoma and you performed a biopsy. It has come as squamous cell carcinoma. You have confirmed the diagnosis. Now you have done a CT scan. Now you have the staging ready. Now you have to go for treatment. What do you suggest for this patient? Before you go for this treatment, the basic attitude with which you are going to look at the treatment is that you want to preserve his voice. Preserve his voice. Now, this is now agreed that this is a patient of carcinoma larynx. He has been smoking all throughout his life. Now, the first thing that you will think of is remove the larynx, give him a good life. But if you do not give him a voice, the first way you want to communicate with somebody is voice, right? Without a voice, he will have a huge handicap. And also he will have a stoma through which he cannot take a head bath anymore. He cannot go swimming anymore. So the attitude is you preserve his voice. You preserve the organ. Organ means the voice box. You preserve his voice box. So the basic treatise or the basic attitude is you preserve his voice and you do not go for surgery as a first line of treatment. So the emphasis is on preserving the larynx along with control of the disease. Definitely we have to control the disease. This is obviously the main thing, but try to preserve the larynx as much as possible, okay? Laryngeal preservation should be the intention. The intention is to preserve the larynx while treating carcinoma larynx, as it gives a better quality of life. Without a voice, his life is like, no, it's not complete to the patient. Hence radiotherapy is given preference. So whenever a patient of carcinoma larynx comes, first you are going to think is, can I do radiotherapy for this patient? Can I do radiotherapy for this patient? Can I do radiotherapy for this patient? Only when you cannot do radiotherapy, you think of surgery. Surgery is not the first line of treatment. It is not the first line of treatment. The first line of treatment is radiotherapy. So think in terms of radiotherapy all the time. Coming to stage 1 and stage 2 carcinomas of the larynx. Stage 1 and stage 2 means stage 1 means T1, stage 2 means T2, N0, M0, N0, M0. So stage 1, the tumor is limited to one subsite or site, so it can be carcinoma limited to only the vocal cords. Most of the presentation will be like this only. You may find accidentally a case where the tumor is located only in the epiglottis, but these are rare things. So you have a tumor which is on one vocal cord, he's having mild hoarseness of voice. He has come to you. You have diagnosed it as carcinoma larynx. So stage 1 and stage 2, it is also vocal cord carcinoma going a little bit into the false cords. Adjacent subsite is involved, or with impaired vocal cord mobility. Impaired vocal cord mobility means there is some infiltration of the tumor into the thyroarytenoid muscle or trichoarytenoid joint, or maybe recurrent laryngeal nerve. Not the chances of having a recurrent laryngeal nerve invasion in stage 1 and stage 2 is less. Mostly it will be thyroarytenoid muscle invasion. So there is either vocal cord mobility is impaired, or it has extended to the adjacent subsite, or it is in one subsite. So this is stage 1. So stage 1, what do you do? As we said, external beam radiotherapy is the treatment of choice. This is the first step. When you say step 1 and stage 2, the first thing that you think of is external beam radiotherapy. You think of external beam radiotherapy. So this is how you approach the patient, right? Because it is organ and voice preserving. Okay, suppose unluckily 90% of the patients will not have any recurrence. You will have a success rate in 90 to more than 90% of the cases. Okay, but unluckily, if the patient recurs means the disease has come back, means the patient has presented again with a growth after giving radiotherapy. So there is a growth. Now you go for surgery. So another principle of treatment is that if you initially give radiotherapy, you have to follow it up with surgery. If you go initially for surgery, you have to go with radiotherapy. You cannot follow a radiotherapy with another radiotherapy. You cannot follow a surgery with another surgery. So if you have done radiotherapy as initial choice, initial treatment, then you go for surgery. If you have done surgery first, then you go for radiotherapy. So this is the principle. So once you have done radiotherapy, you go for surgery. Still in this surgery also, you want to save his voice. Okay, if the recurrence is in stage 1 and stage 2, you go for voice conservation surgery. We are going to talk about it in detail next slides. Voice conservation surgery. The first one is called the vertical partial laryngectomy, where one vertical half of the larynx is removed, or horizontal partial laryngectomy, where the above half of the larynx, or a partial laryngectomy, half of the larynx, you give a horizontal incision and remove the above half of the larynx. So you can go either with a horizontal partial laryngectomy or a vertical partial laryngectomy. Suppose this fellow has not come up with regular follow-up, or maybe the tumor was very aggressive and the patient presents to you again with stage 3 and stage 4. Now this is the bad news. Stage 3 and stage 4A, you go for total laryngectomy. You do not have a choice. Stage 3 and stage 4 recurrence. Stage 3 and stage 4 recurrence. Now let me repeat. Stage 3 and stage 4 recurrence. You do not have a choice. You go for total laryngectomy. So let me just repeat this one. A patient has presented to you with stage 1 and stage 2, you just directly go for external beam radiation, which is organ and voice preserving. You will get more than 90% success rate. Suppose, unfortunately, if the patient recurs, you tell the patient, follow up. I want you to keep coming every 3 months, every 6 months later. I'm going to do a video laryngoscopy and see if there is a growth. And if there is any symptom like hoarseness of voice, please do come back early. Okay, if the patient recurs, you go for surgery. Recurrence after radiotherapy, go for surgery. You do not follow a radiotherapy with another radiotherapy. If the recurrence is in stage 1 and stage 2, you are lucky. Still, you are trying to save his voice. What do? You do a vertical partial laryngectomy or a horizontal partial laryngectomy. Unfortunately, the patient has recurred in stage 3 and stage 4A. You do not have any choice. You go for total laryngectomy. Okay. Now, this is the way you are going to approach. Okay, but there is also an alternate way you can approach this. This is only for a select set of patients, a very selective set of patients. What is that surgery that you can give to the patient in a very selective group of patients? It is endoscopic laser cordectomy with MLS. So what is this? You are using an endoscope. You are looking into the larynx with a endoscope with a camera. You are doing a microlaryngeal surgery. You are using a laser. It is not a cold knife instrument. You are using a laser and you are doing cordectomy. You are removing the vocal cord, involved vocal cord. So it's endoscopic laser cordectomy with MLS. This is the alternate step 1. That is surgery. If you advise surgery for this patient, in which patients can you go for this special criteria, special surgery that you can do? Only in glottic carcinoma. Only if it is in early stage 1. Only if the tumor is small and it is not bulky. Bulky means the laser cannot burn up entire thing, right? So it has to be small, and all the margins are visualized endoscopically. Suppose this is the larynx. It is a part of the growth is going into the ventricle, and you cannot see the margins. Only when you can see the margins completely, the entire margins of the vocal cords can be seen endoscopically. Only then you go for endoscopic laser cordectomy with MLS. So these are very small subset of patients who are presenting very early stage 1. He is not also telling stage 2, early stage 1. And also you are trying to remove the tumor with a laser. You cannot keep on shifting the position of the patient. With one view, with under a microscope or with an endoscope, you can see the entire margins of this growth. One margin of the growth is not going into the ventricle, and they are not bulky, they are not big, they are just small, just like concretions just coming above the surface, and you confirm that it is carcinoma. Only those early subset of patients who are presenting very early, like glottic carcinoma, early stage 1 glottic carcinoma, small, not bulky, and the margins can be seen very clearly, you you advise this as the first step. Only in this subset of patients, you advise this surgery, endoscopic laser cordectomy with MLS. Why are you giving so much of importance to this endoscopic laser cordectomy as the first step? Because radiotherapy, even though we are curing the patient, radiotherapy has got its own side effects, right? And radiotherapy, you should see the side effects of the patient, especially those who are having carcinoma of the oral cavity, carcinoma of the tongue. For many years, he's going to have xerostomia. He's going to have a dry mouth throughout. Eating will become difficult. You cannot sit peacefully with a dry mouth. Xerostomia will be there. Some patients will end up with hypothyroidism. Some patients will have chondronecrosis. I have seen a case of carcinoma of the tongue. The radiotherapy was given and the patient developed osteomyelitis of the jaw. So these are the kind of side effects that are going to endure with him for a very long time. So if that lucky patient comes to you with early stage 1 glottic carcinoma, which is small and not bulky and the margins are clearly visible, you do a laser cordectomy, endoscopic laser cordectomy with MLS. You are having a brilliant view of that enlarged illuminated view of the growth on the screen, and you can remove it by using a laser. You're not using a cold knife again. It is not a cold knife surgery. So the advantages are, one is definitely you're preserving the voice of this patient. That is the most important thing. Second is you are avoiding the side effects of radiotherapy, that is xerostomia, hypothyroidism and chondronecrosis. And the one more important thing is you can do the surgery of this patient with a laser and basically send him home the next day or the very next day, right? It's a very low morbidity to the patient. The surgery may finish very early, or in less than 30 minutes. But radiotherapy has cycles, and radiotherapy takes a minimum of 6 weeks. So you are getting rid of the surgery in 1 or 2 days. So your short hospital stay and the radiotherapy side effects are avoided. So because of these advantages, you prefer surgery in only this subset of patients: early glottic carcinoma, small stage 1, early stage 1 glottic carcinoma who is having a small and not a bulky tumor, and all the margins can be visualized clearly. Suppose unfortunately you did a cordectomy and the tumor recurred, you go for radiotherapy, because we saw the principle of surgery. Radiotherapy is again voice preserving. Okay, the principle of surgery we said, right? That if you go for radiotherapy, you go for surgery. If initially radiotherapy, then go for surgery. If initially surgery, then go for radiotherapy. So here we went for radiotherapy as the first step. Then if it recurred, you go for surgery. Here you have gone with surgery as the first step. You go with radiotherapy as the follow-up if in case it recurs. Coming to voice conservation surgeries. Voice conservation surgeries, I want you to have a proper clarity saying that it is indicated only in cases where the patient has come to you, you have given radiotherapy. Okay, but unfortunately tumor has recurred, which means radiotherapy has failed. Only in recurrences you go for voice conservation surgery. You do not go for voice conservation surgery as a first step. You go for voice conservation surgery only in cases of recurrence. Only in cases of recurrence. After radiotherapy. So recurrence. So that has recurred. You have given radiotherapy, it has recurred, only then you go for surgery. In that surgery, what we try to do is we try to voice conservation surgery. We try to conserve the voice. Okay, what are the 2 surgeries that we can do for this case? And also only in stage 1 and stage 2, right? Stage 1 and stage 2. Most of the cases you can catch them in stage 1 and stage 2 because you will be asking the patient to come and follow up. The patient is already alert because he has already gone through the treatment of carcinoma, the trauma of getting diagnosed as a carcinoma, so he will be alert. So most of the times you will get it in stage 1 and stage 2. If the tumor is really very, very aggressive, you may find in stage 3 and stage 4, but mostly it is stage 1 and stage 2. So I'll repeat again. A patient of carcinoma glottis, stage 1 and stage 2 came to you. You give radiotherapy, you follow up the patient. 90% of them don't recur. If they recur, then you confirm it again, and then you have to advise voice conservation surgery if the recurrence is coming in stage 1 and stage 2. If it is stage 3 and stage 4, you go for total laryngectomy. So what is vertical partial laryngectomy? One vertical half of the larynx is removed. This is vertical partial laryngectomy. One vertical half of the larynx is removed. And the most important step is that vocal cord which is removed, you reconstruct it with strap muscles. So the reconstruction is an essential part of this procedure, because this is a voice conservation surgery. You have to, the resected vocal cord is reconstructed with strap muscles. So what, in which cases it is indicated, one vertical half of the larynx is involved with subglottic extension not more than 1 centimeter. So subglottic extension, subglottis means it is having a lot of lymphatic spread, and it is not good for the patient. So if subglottis is more than 1 centimeter, the subglottic spread extension is more than 1 centimeter, you cannot take up the patient for vertical partial laryngectomy. We have pictures also, we will discuss it in detail again. So what is horizontal partial laryngectomy? Horizontal partial laryngectomy, supraglottis is removed. The upper half of the glottis, this is supraglottis, and then vocal cords are there. This is the cricoid cartilage. This is the thyroid cartilage. One supraglottic, the upper half of the larynx is removed. The advantage is voice is good because you are not touching the vocal cords. And now the glottis lies below the base of the tongue. Now once you remove this is the tongue, now you have the epiglottis, and there is the vocal cords here, and from here the subglottis and the trachea starts. Suppose you remove this one, glottis, you remove the epiglottis, you remove the epiglottic folds, you remove the arytenoids. What happens? The vocal cords are lying just below the base of the tongue. So whatever he eats, there is no epiglottis, there is no epiglottic fold, there is no arytenoids. All this will just close when you swallow, right? As part of the swallowing reflex, the whole thing will just close upon itself, and it will prevent even one drop of water from going into the trachea through the vocal cords. But because this patient now he's lost the upper half of the larynx, the supraglottis, so there is a high chance of aspiration for these patients. The voice is good because you are not touching the vocal cords, but there is a greater chance of aspiration, and you do it only in patients with good pulmonary reserve. Now, what are those patients who are smokers for 30-40 years with good pulmonary reserve? Very few patients will have that. If the patient will have COPD, so this chance is less, but there may be some patients who are non-smokers, or because of something they got carcinoma of the supraglottis, and the supraglottis is in stage 1 and stage 2. This is very rare actually to find such a patient who is now you have given radiotherapies presenting supraglottic growth, who is present, who after recurrence is presenting stage 1 and stage 2, and you remove the upper half. These are very small subset of cases, but it's very important to know it because this is an important question both from the NEET PG and the MBBS final part 1. So it is important to know what is vertical partial laryngectomy, what is horizontal partial laryngectomy. So again, it is involving done for stage 1 and stage 2, not involving the glottis. We have already talked about. We have removed the entire part above the glottis. If the glottic carcinoma is removed, obviously this you cannot go ahead with this procedure. You can do T3 carcinomas also. T3 carcinomas, we said T1 and T2, but you can do T3 also. T3 also only if it is T3 because of pre-epiglottic spread. Now we said T3 if there is vocal cord fixity, if there is post-cricoid involvement, if there is pre-epiglottic involvement. Any of these three will put the patient in T3. If the vocal cord is fixed, which means glottic involvement, supraglottic laryngectomy or horizontal partial laryngectomy cannot be done. Okay. And post-cricoid again, because we are not going near the glottis, you cannot remove the post-cricoid area. So this procedure cannot be done. Only if it is pre-epiglottic. Pre-epiglottic means that part just in front of the epiglottis, right? Where that part will be removed. So you can do supraglottic laryngectomy. Now coming to vertical partial laryngectomy, again I want to show you a diagram. Here this is the hyoid bone, this is the thyroid cartilage, this is the cricoid cartilage, these are the thyroid rings. This is the thyrohyoid membrane, this is the cricothyroid membrane. Okay, so what is being removed? One half of the thyroid lamina is removed. Okay, when you remove this, obviously you are removing the false cord. You're removing a true cord. A part of the glottis is removed, which is 1 centimeter below the vocal cord. A part of the subglottis is removed. A ventricle is removed. Along with this, the growth is coming out. Okay. So almost more than 2/3 of the lamina, the thyroid lamina is removed. Okay, this defect that you have here, you try to cover it with strap muscles. Strap muscles. You can see this. This is strap muscle that is being taken here. There is a vein, there is an artery here, and also a cartilage is also placed. Why are you playing the cartilage? Because this cartilage will form some kind of place where the other vocal cord can come and touch. So this cartilage, the other vocal cord, can come and touch and produce voice. So this you're taking a composite graft which is having its own blood supply and trying to fill in this defect, so that you are giving voice to the patient. If not his own original voice, the patient can speak, patient can communicate. So again, one vertical half of the larynx is removed and the vocal cord which is resected is reconstructed with strap muscles. Tumor involving one vertical half of the larynx with subglottic extension not more than 1 centimeter, because you are going even into subglottis. But if the subglottic extension is more than 1 centimeter, you cannot perform vertical partial laryngectomy. Now coming to horizontal partial laryngectomy. Horizontal partial laryngectomy, this diagram is a beautiful diagram. So the upper half of the thyroid lamina is removed, okay, along with the thyroid cornu. You are leaving the hyoid behind. Entire thyrohyoid membrane is also removed. Okay. Looking from the other side, the epiglottis with the pre-epiglottic space is removed. Pre-epiglottic space, paraglottic space, everything is removed. As I said, the half of the thyroid lamina is removed. Thyrohyoid membrane is removed. Entire supraglottis is removed. Okay. So here there will be epiglottic folds. Here there will be arytenoids. Arytenoids are not removed. Okay. So this part is removed, this half is removed. Here supraglottis is removed. Voice is good because the vocal cords and the arytenoids are not touched, so voice is good. Glottis lies, now this is gone. Now the base of the tongue lies below this. The glottis lies below the base of the tongue. So aspiration risk is high. So done in patients with good pulmonary reserve. So done in patients with good pulmonary reserve, because he can cough out whatever comes into the larynx, he can cough out. So this is done for stage 1 and 2 tumors not involving the glottis. Obviously, when it is involving the glottis, you cannot perform the surgery. The tumor is somewhere here above. The tumor is somewhere here above, or in the pre-epiglottic space. Now, one caveat to that is, okay, T3 carcinomas also, because of its pre-epiglottic space, because this part is being removed in this surgery, you can take up this case. T3 because of pre-epiglottic spread only. T3 is also vocal cord fixation. T3 is also post-cricoid area. But if it is T3, if it is causing vocal cord fixation, if it is causing post-cricoid area involvement, you cannot take up this patient for horizontal partial laryngectomy. I hope now you have got some idea about the horizontal partial laryngectomy, vertical partial laryngectomy and horizontal partial laryngectomy. What kind of what do you remove in vertical partial laryngectomy? What are the cases that you can take up for vertical partial laryngectomy? What are the cases you take up for horizontal partial laryngectomy? Now coming to stage 3 and stage 4A. What is stage 3? Stage 3, we said, if there is vocal cord fixity, if there is spread to the pre-epiglottic space or post-cricoid area, it is T3. T4A means it is invading through the thyroid cartilage or tissues beyond larynx locally. So these are, क्या बोलते हैं ना उसको, जमीन आसमान का फर्क है. When if there is thyroid cartilage invasion, if the tumor is going through the thyroid cartilage, you deal with it in a totally different way. If it is going tissues beyond the larynx locally, you deal with it in a totally different way. In T4 itself, there is so much of variation in the treatment. Okay, so that's why thyroid cartilage invasion becomes like a cornerstone, like a benchmark, whether there is thyroid cartilage invasion or not. We will see why. Okay, so what is stage 3? Stage 3 is T3 or N1. N1 also comes under stage 3. Stage 4 is T4A. T4A means through thyroid cartilage invasion or tissues beyond larynx locally. N2 comes under stage 4A. Okay. Now before we go to the treatment, let us just have a bit of clarity on what is concurrent chemoradiation, what is adjuvant therapy or adjuvant radiotherapy. Okay. Concurrent chemoradiation means chemotherapy is administered on the same day as radiotherapy. Chemotherapy is administered on the same day as radiotherapy. So chemotherapy and radiotherapy are given not one after the other but on the same day. That is why it is called concurrent chemoradiation. Now concurrent chemoradiation is what is the first line of treatment for stage 3 and stage 4A carcinomas. Okay, adjuvant therapy. Adjuvant therapy means therapy is delivered after the primary treatment to destroy remaining cancer cells. So adjuvant therapy means the treatment is given after the primary treatment. Primary treatment, suppose is surgery, you give adjuvant radiotherapy. Okay, so this is given after the primary treatment. Concurrent chemotherapy and radiotherapy on the same day. Okay. Now coming to stage 3 and stage 4A carcinomas, as we said, organ preserving, we want to preserve the voice box. So the first step, initial, can I give concurrent chemoradiation with cisplatin to this patient? This is the question that you ask yourself. Can I give concurrent chemoradiation with cisplatin? That is, you are giving radiotherapy plus cisplatin on the same day. In what cases do we, this treatment modality can be indicated? All stage 3 tumors, you can take them up for concurrent chemoradiation. Stage 4A also, you can take them up only if it is stage 4A because of local invasion beyond larynx. That is, trachea is involved, you can take up this case. Esophagus is involved, you can take up this case. Strap muscles are involved, you can take up this case. Okay, muscles of tongue, deep intrinsic muscles of tongue are involved, you can take up this case. Okay, local invasion beyond the larynx, you can take up this case. But if there is thyroid cartilage involvement, you cannot take up this case. Thyroid cartilage involvement means the patient has to go with total laryngectomy with or without neck dissection plus adjuvant radiotherapy. So this treatment modality falls in place once there is a thyroid cartilage involvement. That is why thyroid cartilage involvement is so important. Once there is thyroid cartilage involvement, patient loses his voice. That's it, he loses his voice. As long as there is no thyroid cartilage involvement, you can go with chemoradiation with cisplatin. So stage 3 tumors you can take up. Stage 4A with local cartilage invasion beyond the larynx, that is the trachea, esophagus, deep intrinsic muscles of the tongue, and strap muscles. Also, all these things are involved. Also, you can take up for chemoradiation. Once thyroid cartilage is involved, patient goes into total laryngectomy. So, in which cases you are not indicated? Large stage 4A tumor. So the tumor is very large. Also, this radiation will not burn through it. Okay. So large is always a problem. Large is always a problem. More tumor bulk, you go for total laryngectomy. Thyroid cartilage invasion, you go for total laryngectomy. Cannot tolerate cisplatin, you go for total laryngectomy. So these indications, these three subsets where you cannot take up the patient for chemoradiation, where concurrent chemoradiation with cisplatin, you take up the patient for total laryngectomy. Why we are stressing so much on concurrent chemoradiation? Because again, organ preserving, patient's quality of life is better, voice is preserved, patient can go swimming. Okay. So again, concurrent chemoradiation is indicated in stage 3 tumors, stage 4A. When it is stage 4A because of invasion beyond larynx locally, not indicated in thyroid cartilage invasion. Thyroid cartilage invasion, patients who cannot tolerate cisplatin, large bulky tumors, you take those patients up for total laryngectomy. What are the benefits of this chemoradiation? It follows the principles of our management, that is, it's organ preserving, gives better quality of life to the patient. So total laryngectomy is never done separately. Chemoradiation with cisplatin, you can do it separately, but here whenever you do total laryngectomy, if the nodes are very big, you go for neck dissection. Okay, and then you also compulsory add adjuvant radiotherapy. Total laryngectomy will be incomplete if you do not add adjuvant radiotherapy. So you do a total laryngectomy, you remove the entire larynx, you palpate for any nodes. If the neck dissection is needed, you do it. Definitely you send the patient for radiotherapy. Total laryngectomy, you never do it alone. You always follow it up with adjuvant radiotherapy, adjuvant given after the primary treatment. So what are the indications? For cases which are not indicated to do chemoradiation, these are the same cases. Stage 4A with thyroid cartilage invasion. Stage 3 or stage 4A who cannot tolerate cisplatin. Stage 2, radiotherapy is enough. So we are not mentioning about. And also this one, recurrence after radiotherapy, now presenting in stage 3 and stage 4. Stage 3 and stage 4, recurrence. It is not a fresh case. Stage 3 and stage 4 recurrence. Stage 3 and stage 4 recurrence, you go for total laryngectomy. Stage 3 and stage 4 recurrence, you go for total laryngectomy. Stage 3 and stage 4 recurrence, you go for total laryngectomy. Stage 1 and stage 2 recurrence, you go for voice conservation surgeries. That is vertical partial laryngectomy and horizontal partial laryngectomy. Okay, so I guess I am clear with this. Now, total laryngectomy specimen looks like this. You are removing the epiglottis, the vestibule, the vocal cords are here, the false cords are here, the vestibule, okay. This is the ventricle, false vocal cords, true vocal cords are removed, and you are there, the glottis, the subglottis, all these things are removed. So this specimen looks like this after the you remove a part of the trachea also. So this specimen looks like this, the total laryngectomy specimen. Now, to understand this, this is the stoma of the patient. The patient's trachea is now communicating directly with the outside. You have sutured the pharynx in place so that whatever he eats, it goes into the pharynx. This is the tongue. This is the oral cavity. The food goes into the trachea. Okay, neopharynx you call it. Neopharynx. Okay, so this is the total laryngectomy specimen and how the stoma comes out. Coming to side effects of cisplatin, this is important. If you start giving cisplatin and the patient develops nephrotoxicity, if the patient develops sensorineural deafness, if the patient develops neuropathy, it means the patient cannot tolerate cisplatin, and such patients you go for total laryngectomy plus or minus neck dissection plus radiotherapy. This is not plus or minus. This is plus or minus, but this is always plus. Adjuvant radiotherapy is always there. Nephrotoxicity, sensorineural deafness, neuropathy. So these are the three side effects of cisplatin. So when you start cisplatin, you have to keep looking at these things. Okay, now coming to the last, this is near total laryngectomy. Okay, so near total laryngectomy, just to complicate the matters more for a student, but for saving the life of the patient, making his life better. What is near total laryngectomy? Near total laryngectomy is the same as total laryngectomy. Only one thing is, this patient has growth where one uninvolved arytenoid, the growth is involving the right vocal cord, anterior commissure, left vocal cord also involved, right arytenoids involved, piriform epiglottis, everything is involved. Luckily, somehow the left arytenoid is not involved in this case. Such cases you take up for near total laryngectomy. Why you want to take up for near total laryngectomy? Because you can give him a better tracheoesophageal speech. Okay. So what do you want to know about this? What you have to understand about this total laryngectomy, near total laryngectomy? It is not a voice conservation surgery. Do not put it in the same subheading or under the same category of vertical partial laryngectomy and horizontal partial laryngectomy. It is not a voice conservation surgery. It is not done for radiation failures. Voice conservation surgeries are done for radiation failures. This is not done for radiation failures. It is done for fresh cases. The indications for near total laryngectomy are the same as that of total laryngectomy, like large T3, T4A with one uninvolved arytenoid, with thyroid cartilage invasion. Same thing, whatever thyroid, total laryngectomy, whatever the indications are there, right? Total laryngectomy indications are large stage 4A with thyroid cartilage invasion, stage 3, 4A cannot tolerate cisplatin, recurrence after RT now presenting with stage 3 and stage 4A. The same indications will apply for near total laryngectomy. Okay, stage 4A with thyroid cartilage invasion. So but there is one caveat to this: one uninvolved arytenoid. Luckily in this patient, unluckily for the students, one arytenoid is not involved by the tumor. Such patients you can take it up for near total laryngectomy. For whom is it recommended? For patients who present late, obviously. Stage 3, stage 4 means late, okay, who are not candidates for concurrent chemoradiation because of thyroid cartilage invasion and side effects of cisplatin. The patient having thyroid cartilage invasion cannot tolerate cisplatin, you take it up for total laryngectomy or near total laryngectomy. If one uninvolved arytenoid is there, you can take it up for near total laryngectomy. So, near total laryngectomy, in this diagram, you remove the entire larynx except for one uninvolved arytenoid. Okay, whole of the larynx except for the uninvolved arytenoid is removed. Why? Because the tracheoesophageal pathway for the speech can be made better if there is a one uninvolved arytenoid. It gives better speech than total laryngectomy. So you, at every possible step, what can I do something for this patient? Can I do something for this patient so that his voice is a little better? You only think about it throughout the way. Now, coming to the last and the final stages, these are the real unlucky patients. You can't do anything about these patients. Stage 4B and stage 4C. What is T4B? It is invading the larynx to distant places like prevertebral space, mediastinum and carotid. These are unresectable. You cannot remove them. Neither can you give radiotherapy to these really sensitive structures, prevertebral space, all this. If the vertebra collapses, that's the end of him. So such patients, you go for palliative radiotherapy. You give something so that the patient can have a little bit of life for a few more days. Okay, stage 4B, still T4B, the same thing, invades the larynx beyond to distant spaces. T4B means stage 4B. N3 is also stage 3. N3 means tumor greater than 6 cm. Sorry, lymph node greater than 6 cm. It can be single or multiple. Unilateral, contralateral, bilateral, anything greater than 6 cm comes under N3. Okay, stage 4C, any N, any T, any M. M1, that is metastasis is present. Metastasis anywhere in the body. Okay, once metastasis means stage 4C. So such patients you give palliative radiotherapy. You try to prolong his life for a few more days. Give him a few more days of a life that is as close to normal as you can. Okay. Now, just revising what we learned in the treatment, the principle of management is you want to preserve the organ. You have to preserve the voice. Okay, the voice preserving is important. So stage 1 and stage 2 tumors, the first thing you think is radiotherapy, external beam radiotherapy, external beam radiotherapy. Okay, suppose 90% of the patients will have success rate. Suppose it fails, you go for stage 1, and if the presence comes back again in stage 1 and stage 2, you go for voice conservation surgery. He comes back in stage 3 or stage 4B, stage 4A, sorry, you go for total laryngectomy. You don't have any choice here. Till here, you try to save his voice. Oh, sorry. Okay. Now coming to what is stage 3 and stage 4B, what do we try to do? You think of concurrent chemo radiation with cisplatin. Concurrent chemo radiation with cisplatin is the first choice, as long as there is no thyroid cartilage invasion. No thyroid cartilage invasion. Now this is important. Once this thyroid cartilage has got invaded, you don't have any choice. You have to go for total laryngectomy plus or minus neck dissection plus adjuvant radiotherapy. This is the treatment of choice. Okay. Stage 4B, distant places, and stage 4C. So this is 4A. 4B and 4C, you go for palliative radiotherapy. So this is the treatment protocol. Voice conservation surgeries, you will have horizontal partial laryngectomy, vertical partial laryngectomy. Okay. You have one subset, total laryngectomy. Along with it, you have near total laryngectomy with one uninvolved arytenoid. One arytenoid is miraculously saved, so that you can do a better tracheoesophageal pathway, so that you can give a better speech to the patient. Thank you for the patient listening. I hope I can be as clear as I can, but this requires repeated study and a little bit of thinking about it. It's just not just you read it and forget it. Just sit back when you are, when your mind is fresh after drinking a cup of tea maybe. So your mind is fresh. Just recap. What is stage 1? What is stage 2? What is stage 3? What is stage 4? Stage 1 and stage 2, what do you do? Stage 3 and stage 4, what did you do? What are these? I did not mention about endoscopic laser cordectomy. So what are these? This is the main path. This is the main highway, right? The radiotherapy and concurrent chemoradiation. What are these subset, like the other small roads that go endoscopic laser cordectomy, horizontal partial laryngectomy, vertical partial laryngectomy, near total laryngectomy? Just close your eyes and go through it. Revise it. I hope this does not remain a very difficult topic which scares you. I hope I have made a part in it, played a part in it, so that it makes your life a little bit easier. Thank you.